Thank you. Thank you. Morning, everyone. I'm going to talk to you mainly about the sexual health review that we were asked to undertake by Welsh Government going back to November 2016. So in my presentation, I'm going to briefly cover what were the objectives that we were given for the review, what were the methodology that we adapted, what are the key findings, and what are going to be the next steps following that. So that's broadly where I will focus my presentation on. Before I start, I would like to thank Welsh Government. I'm very grateful that Welsh Government asked Public Health Wales to undertake this review, so I'm very grateful for that. So, So back in, as Chief Medical Officer mentioned, back in 2016 November, the then Minister for Social Services and Public Health announced that there would be a comprehensive review of sexual health services in Wales. As part of that review announcement, there were very specific key objectives that we were asked to consider, and these were those objectives. So, which was one, to look at the needs assessment, particularly of those clients accessing services at the integrated sexual health services, and as part of the needs assessment, understand and undertake an assessment of unmet need. What is it that we're not catering to? And then predominantly looking at assessment of risky behaviors, in engaging and understanding the scale and nature of all the risks across the population groups, and to look at what is currently being provided in the integrated sexual health services, including looking at the cost effectiveness of the existing models of service. I'll come on to the bit, but why we weren't able to do the cost effectiveness of it in quite some detail. Then there was also an ask to look at the consideration for sharing patient information across the continuum of care between primary care, secondary care, community services, in respect of specific legislations that there exist in sexual health, particularly the venereal disease regulation, which is quite old now. And finally, to consider, based on all of the findings, what is it that we can look at as potential for targeted intervention, both at a population level as well as a target towards high-risk population. So these were the 6 objectives that we were given for the undertaking the survey. CMO has already mentioned that the governance for this whole program was overseen by the Sexual Health Program Board, chaired by CMO. So in the context of this review, we were looking at a number of different services that provide sexual health services in one form or another across various spectrum of care. This could be from primary care, community services, pharmacies, general practice, integrated services, secondary care, etc. So we wanted to look at the whole picture. But clearly there were 2 important things which are sexual health related, which were outside the scope of this review, those being, one was the sex education, and we did not particularly look at that. And the reason for that being that Welsh Government's already undertaking a curriculum review through the Department of Education. And then as part of that review, an expert panel has already been established who is looking particularly at sex education in schools. The second element that we kept out of the scope of this review was sexual assault referral centers, SAR. Again, the need for that did not rise because that service had been only very recently already been reviewed. So in that context then, this is basically the summary of work done. I've tried to capture this in one slide, but it is in no means a reflection of what has happened. This has been an incredibly hectic year in 2017, starting from January up until now. So along with myself giving some of the consultant level support and steer, bulk of the work for this work has been done by my colleagues Zoe Cousins and Adams, who's you will hear a bit later, very much supported by everybody in and around the systems. So we started off by, I will go into the details of these a little bit more in detail, but we started off by looking at the State of the Nation report, what is happening in the world of sexual health currently, and then looking at the review of current service provision, And we undertook a specific patient survey identifying what are the client's requirement in terms of the services that they would like to see, how would they like to access, what sort of care they like to see. Then we undertook a specific needs workshop by looking at high-risk population as well as people who may be disadvantaged, marginalized, etc. And then we undertook analysis of student sex survey in collaboration with Swansea University. And then we also looked at the legislative aspects through a specific task and finish group. And then we looked at reviewing or drafting a set of service specifications that could be used to benchmark services across Wales. I'll talk about those in a bit. So this is what work has happened till now. What is still going on is we're looking at developing a risk register, calculator, particularly looking at what sort of risk factors predisposes somebody for getting sexually transmitted infections. And this is work we are carrying out in conjunction with our colleagues in the Policy Research and International Development within Public Health Wales through some modeling work. We're also looking at qualitative analysis of adherence to PrEP, which has recently been started. You will hear more about PrEP later on in this morning as well as during the day. So we look at the State of the Nation report that we produced here. I think this graph is quite important, looking at conceptions and abortions. People will be familiar that the most important data that keeps getting quoted to us all the time is that 1 in 6 pregnancies in Wales is unplanned. So that's what we see, that 16% are unplanned pregnancies. And then 4 out of 10 pregnancies actually end in abortion are actually planned or ambivalent. So this graph here shows the conception rates among 1,000 women in each age group. This is in the year 2015, and the red line shows the percentage of those conceptions that end in abortions. We can see that, as you would expect, the highest conception rates will be in the 25-29, but we're still seeing abortion rates varying quite dramatically across. But the most important thing is 1 in 6 pregnancies are unplanned. And then we looked at key sexual health, sexually transmitted infections, particularly chlamydia, gonorrhea, HIV, and syphilis. And this is what happens. And if you look at data from 2016, we had over 12,000 diagnoses of sexually transmitted infections. Understandably, as you would see in the rest of the UK and Europe, half of those were due to chlamydia, and then the other, we had significant proportion with gonorrhea, and of course, although number-wise it may be small, but significant burden in terms of HIV and syphilis. If we look at are we testing the right people? Are we doing enough tests? Are we testing the right people? We look at it, the number of individuals tested has also gone up from 58,000 to 64,000. The positivity rate has almost remained stable at 10%. Again, with gonorrhea, it's a similar picture, 1% positivity, but a slight dip in 2016, but maybe nothing much to read into. We will have to see what the 2017 data is there. Although we are concerned, we're looking at drop in the percentage, but we are also worried that there is drug-resistant gonorrhea that we've been made aware of, particularly azithromycin-resistant gonorrhea, which will be very difficult to treat. Then we looked at over 35,000 individuals who were screened for syphilis. The positivity again has remained stable. And then if you look at HIV over the last 10 years, we've got a total of 1,500 individuals newly diagnosed with HIV. And again, there's this year-on-year variation in that. But one of the things that I come back to in the main finding is that we need very good surveillance system for identifying HIV infections. At the moment, we do have, and if somebody asks us how many new cases of HIV we have in Wales, we will not be able to give a definitive answer based on one source. There are at least a number of sources. Depending on which source you look at, you get a different answer. So we need a better surveillance system for HIV. Again, then in terms of accessing the services, what we did was, in order to look at what is the current service provision, we took a representative sample of the activity over a 1-week period. And this we did in the week beginning 8th of May, where we asked all the services to provide us with a detailed list or information about their staffing levels, their cost, the type of patient seen, the number of patients seen, where they saw, what was the complexity, a very comprehensive one. And what emerged from analyzing that data was this. So we just tried to map the location of different services. I apologize because there's small dots on a map, you may not be able to see that very clearly. What the main message is, whether you're looking provision of emergency hormonal contraceptive or long-acting reversible contraceptives or the condom provision, there is scattered all over the country, predominantly South Wales, and we have locations in between in the Powys area, bits the North Wales area, where there is opportunities to capitalize on that. The service providers are there. We need to make more. We need to make those services more accessible, so people don't feel that they have to travel far to get their service. This is just a snapshot on emergency hormonal contraceptives that we have looked at in that 1-week period. I just want to draw your attention to this fact that we are spending close to £600,000 on emergency hormonal contraceptives, and with a number of providers there. Whereas if you think, and then here in the bottom we see that the proportion of those clients who used emergency hormonal contraceptives that are coming back within 6-month period to again access emergency hormonal contraceptive, it's quite staggering. Over half of them are coming back to us, meaning that if we identify these high-risk behaviors and put them instead of hormonal contraceptive on either depot or long-term reversible contraceptive, they not only benefit, there's reduced attendance, there's less risk, and it's more cost-effective. So there are lots of opportunities for us to change the way in which we provide service, which is actually meeting the requirements of the clients. Again, in this slide, I'm just trying to show what proportion of sexual health testing is actually provided in primary care in GP surgeries. And again, you can see that depending on the health board, there is a variable level of provision. It could vary as low as 20% to as high as 60%, but overall we are at about 50%. Only 50% of all GP practices are performing STI testing. Again, this shows in the bottom table here, across Wales, the contraceptives prescribed per 1,000 women in the 13 to 49 year age group, was that its emergency contraception is 8%, long-acting is 20%, but the conventional pill is still by far the most commonly prescribed contraceptive. Here is the fact that CMO mentioned earlier in his address that the services are under pressure. We're seeing more patients. This graph reflects that. In the last 5 years, the attendances at sexual health services has doubled from 86,000 to 170,000, which is absolutely staggering. And then the services themselves have not been adequately resourced to cope with this level of demand. And what we also see in the map on the left side is those red dots where service provision location of sexual health clinics, and the purple shading around those red dots indicates the boundary which is within 15 minutes of car travel distance. So you can see that in this map, that's a large portion of Wales where people have to travel more than 15 miles, for more than 15 minutes to actually reach the nearest sexual health provider, which again is something we need to look at. And then as part of the service provision, again in that representative week, we looked at data around what sort of clinic services provide, whether it was a walk-in only clinic, whether it was an appointment only clinic, how many patients are seen per hour, what's the complexity, etc. So that's the detail shown in this table. But I think what I would like to draw your attention is that in that representative week, clinics across Wales in a week saw 4,200 patients. But most importantly, I want to draw your attention to this here. 405 of those patients were actually turned away because they were not being accommodated in the clinics. When we looked further into that data, a quarter of those, about 100 patients, were actually category 1 patients who were turned away, meaning category 1, meaning they were symptomatic, they were at high risk, and they needed to be seen urgently, but they were not seen. And then this graph, this table shows the number of legal abortions done. It's about 8,000 in the whole year in 2016. And again, a good proportion, as we saw, is 3/4 of those were medical abortions, 1/4 of those surgical abortions. Ideally, we would like to get this number up 75 to much higher, so that more are seen early in medical access to medical abortions. So that's what we did in the estimation of current service provision. Then we looked at the survey which we undertook to identify what are the views of patients accessing services, mainly to determine what their opinion was on service provision. This is a survey we started in May, and for the purposes of the review, we analyzed responses until October 2017, and that gave us a very rich data set of about close to 1,000 responses, 922 to be precise. We still have more responses that have come through, which we will be analyzing subsequently. So in that survey, we specifically asked questions around reasons for attending the surveys, what was the preferred method that they of attendance, how would they like to book an appointment for, what day of the week they would like to be seen, what time of the day, when they actually see the provider, how would they like to be seen, what sort of privacy they want, and a whole host of very in-depth qualitative sort of responses. And it has given us very good, rich data set. So this is what that survey results showed. So if we look at the reasons for attending surveys, 2 main things stand out. One is to access contraceptive service. The second one was for requesting an STI testing. So we talked about earlier, CMO mentioned the technological advancements in terms of near patient testing, online testing, postal, etc. There may be an opportunity for us to look at it quite differently. Do people actually need to go to a clinic to actually get a test done? Is there a way we could get the test done and then they go to see the provider with their test results, so it reduces the amount of time? There are pros and cons to that whole approach. We can discuss about it. And then, going back, and then the most people prefer to be seen as a drop-in rather than appointment compared to that. And then they did not show any preference of what day of the week they needed to be seen. People wanted to be seen when they had symptoms. They didn't mind which day it was. Similarly, although most the attendees said they didn't prefer what time of the day, but if it was morning and a bit in the evening is when they preferred it to be seen. Then we also looked at what would their preferred method of booking an appointment was. So clearly 35% said telephone, but a higher proportion than that said they didn't have a preference, either it was online or telephone. And in terms of the type of clinic preferred in relation to whether they want women-only clinic, LGBT, young people, then there was a good proportion who said they would like to be seen in a female-only clinic if they were a female client. And they didn't express any particular preference of how they would like to register when they came to a clinic, either by the receptionist or by the touchscreen method. But this is an important finding. 60% of our respondents in the survey said they would consider an online self-taken test, which is something which we need to take into account in the recommendations and action plan going forward. So those were in a nutshell the results of the patient survey. Then we undertook a needs assessment workshop. Again, the purpose of this workshop would determine, through engagement with key populations, the type and the content of surveys that that was required to meet their needs. So we undertook this workshop in two parts. So the first part was to look at what information and resources were required or the clients felt that they needed. And the second part was to look at how the elements of access to surveys. So I'm going to, and then the questions that we asked are what is as shown on the slide. But I will just give you the results for each of those questions that we asked. When they said what information clients needed to know, I think the reality is that the traditional landscape of sexual health has changed in terms of from STIs, contraception to pregnancy. It has moved on from that to much deeper issues such as gender identity, sexual exploitation, pornography, online safety, inappropriate images, drugs, alcohol. So we need to take into account those newer, more in-depth issues. And there is also a need for us, the clients felt they need to be seen more about positive reinforcing messages, about sex-positive messages, whereas all up until now we've been giving information related to risks. So they would like to see that there are more narratives around, within quotes, pleasurable sex, safe sex. So that's what they felt they needed to know. In terms of different info, in terms of when do they need to know? So what age group of clients prefer what type of information to be given? Again, as you would imagine, unsurprisingly, different age group clients need different type of tailored messaging. But I think there was consensus, there was one consistent consensus, irrespective of the age group, that the key information that need to be provided should be provided before they become sexually active. So that is the main message coming out of that. And in terms of media, language, and preference of how they would like this information, consideration, it was very clear from the respondents that the considerations need to be given about different methods of reaching audience, whether it's audio, video, pictorial, social media, etc. So not just the traditional leaflets, etc., which also have a place, but they themselves won't suffice. And then we need to look at different ways of disseminating those to communicate generally in the public health arena. So the second part of the workshop looked at accessing sexual health services. So what would they like to see in terms of initial access? I think one of the things that came up, and we often don't pay much attention, I don't think, to these elements, but when you look at qualitative data, this kind of hits you quite hard, and that was being my reflection anyway, that people prefer to have interpreters booked in advance. It may seem not so big when you do it, but when they turn up and there's no interpreter there, and it's not a satisfactory one. And then there is specific clinics beyond certain young people group. And again, this one was quite fascinating for me, maybe not so much for you guys who are seeing clients in the service so much, is that there is issues about gender identity, and when people get coded with an M or an F against their, that it is fine. But then, and also accessing in a waiting area, if you look at toilets, they're traditionally named men M or F, whereas the transgender people find it absolutely inappropriate for their needs. So we need to make sure that those needs are taken care of. And then in the reception area, what is it that they would like to see? I think they said they would like to see an indication of waiting time, which is how long they may have to wait before to be seen. And then traditional screens whereby we give general public health messages about what key infections, how to identify, how to prevent. And then what would they like to see within the consultation room and the process? Again, there was consensus that patients require reassurance on confidentiality, privacy, And then the service needs to be holistic, not just tailored to that one particular problem that got them to the clinic on the day. And also, they would like to be seen and receive treatment in one visit. They don't want to be coming multiple times, once for the consultation, once for the result, and a subsequent one if necessary for treatment. And then in terms of when we ask the question, how would they like to receive results? I think most people said that they would prefer to receive their results by text messages. However, consideration needs to be given to understanding how they would understand the result coming directly to them without any explanation or interpretation around it, but also not everybody would be comfortable getting a result on their access to mobile phones, etc., etc. In terms of alternatives for service provision, particularly when we ask questions around community pharmacy, general practice, online, I think they're unanimous, a vast majority of them agreed that their alternatives should be considered for the future, and that was centered around making testing more accessible, supported by trained professionals, and written materials along the same lines that has been piloted and tried in England, for example. There was consensus that over-the-counter buying of tests or treatment without professional help would not be appropriate, although currently there is a small proportion of our clients who are actually accessing it through that route. So those were, in short, the results of the needs assessment workshop. Am I doing okay? And then we looked at the other element of the question in the survey was looking at risky behaviors. As we all know that there is a huge component of behavior involved in sexually transmitted infection, sexual health. So working with Swansea University, we reanalyzed the data from the student sex survey, whereby we only took out Welsh resident specific responses as opposed to the UK-wide responses. And there were about 3,000 such responses that we were able to analyze. And again, as the bullet points on the slide are the sort of questions and answers, the questions to which we looked answers for. So when we looked at sources of advice for sexual health provided, the main source of advice had been internet and GP, depending on the age group. So people with increasing age, people prefer to get their information from GPs, whereas the more younger age groups, they unsurprisingly found information through through internet. And then for those who reported their sexuality other than being heterosexual, they were far more likely to go to a sexual health charity or student support services for their advice. And males were half as likely as females to seek advice from parents or friends, and 3 times more likely to report having never needing any advice. Approximately 20% of males reported that they did not need any advice. Again, that's depending on which way you look at it, could be quite worrying. Those who reported having sex for the first time under the age of 16, the most likely place they would seek advice would be variety sources, including internet, pharmacy, and local sexual health clinics. And when the question was asked as to where they would seek treatment related to sexual health, following sexual health, over 50% of them reported never needing treatment. But we know that chlamydia, as one of the most important sexual health infection, is asymptomatic in most individuals. And of those who sought treatment, there was a 50-50 split between GP and sexual health clinic. Males are 40% more likely to believe that they never need a treatment, and are half as likely to have access treatment at a GP or sexual health clinic. And then when we asked individuals about potential barriers for their attendance at sexual health clinic, I think this is some of the results from this was quite an eye-opener for me at least. Those identifying themselves as homosexuals were twice as likely to be afraid of being judged and stigmatized by the staff, or even embarrassed about being seen in these services. Those in the older age group were less likely to report being embarrassed or about being seen or going more likely to a known location of the services. And again, homosexuals were twice as likely to report being afraid of being judged than heterosexuals. Some of them, both homosexuals and bisexuals, were more likely to report that they didn't have time to access services. So those are some potential barriers to access. And then when we ask the question of how frequently they access services, and as with responses to the previous questions, males were over a third less likely than females to seek a sexual health check, particularly when they had a new partner. And males were a third more likely to never have had a check at all. And then when we looked at results responsible questions in relation to number of partners and whether they had ever had an STI showed, those identifying themselves as bisexual or homosexuals were more likely to have had 10 or more partners. They were more likely to have had an STI. And the older the respondent, the more the number of partners, and more STIs and less likelihood of practicing safe sex. So, and then finally we asked questions about experience and exposure to the sex industry. So males were 7 times more likely to have viewed online pornography, less likely, and the likelihood increased with age. And those who reported first time having sex under 16 were more likely to partake in sex industry than those who were older when they had first sex. So those were a summary of the findings on the risky behaviors. And then in relation to the data sharing bit, Adam led this piece of work for us. So that we were looking at the Venereal Diseases Regulation Act, and then there were been issues with sharing information across the spectrum. So we set up a task and finish group, and we looked at specific examples where the act had become a barrier for sharing information between 2 care providers, and as a consequence of that, the patient care had been compromised. And so we just took up a number of examples, and then we looked at what's the perspective between balancing confidentiality with care, and we have now made recommendations in an options paper to Welsh Government, which is all part of the final survey report for consideration of how best we can take the amendment to the legislation. So I'm going to summarize then. In summary, the key findings from the 2017 Sexual Health Services Review are that the attendances have doubled in the last 5 years and has exerted considerable pressure on the services. There is variation in the provision of sexual health services, and this could be a reflection of the variation in the contractual agreement between the health boards and the service providers. And those services that have best coped with the increased demand appears to offer a higher proportion of walk-in clinics as opposed to drop-in clinics as opposed to appointment-only clinic, and they also appear to be adequately resourced for that compared to the ones who haven't been able to cope with the demand. The other big issue we found was the IT systems. The current sexual health services IT systems are very, if I can use the word archaic. It is not fit for purpose. It is not definitely representative of a modern 21st century technologically relevant one. So what has that meant is that they do not support the collaboration between different partners and services, and then there is issues with quality and timeliness as far as surveillance is concerned. And so one of the key things we would want to look at is to see how we can improve the IT systems. And then continuing with the findings, then some populations are particularly disadvantaged with lack of provision around rural communities, access to abortion services, and those in prisons. There is inequity in service provision, particularly its relation to service provided by primary care, as well as availability of and accessibility to abortion services. The good news is patients would welcome self-testing in the community as an additional method for accessing the testing. And then there are certain well-established programs such as the condom card schemes who are kind of working in isolation, but they are at risk of vulnerability because of financial pressures. And then the legislation bit I talked about earlier, that sometimes current regulations can themselves become a barrier for joined-up care. So those were the main summary findings. So what will happen next? Then the final summary report has been submitted to Welsh Government through the Sexual Health Programme Board and is under consideration with Welsh Government. But in addition to the 20-page report that we have submitted, the rest of the activity that has gone on to deliver the objectives of the review are captured in these 6 or 7 different documents, all of which together needs to be seen as the whole set of publications for the findings of the review. So I'd like to finally thank everybody that this review would not have been possible without the full cooperation of all the services, whether it's primary care, secondary care, services, etc. Lots of conversations have happened, innumerable number of phone calls, lots of meetings, etc. But I think we're very grateful to all the partners who have helped to contribute to the findings of this survey. Thank you very much.